I'm Neil Kelman, Chair of Family Medicine at Mount Sinai and President of the Institute for Family Health. It's a great pleasure this morning to introduce two very special people. Dr. Diane Meier is the past CEO of the Center for Advanced Palliative Care, a national organization devoted to increasing access to quality palliative care for people living with serious illness and their families in the United States. Under her leadership, the number of palliative care programs in the US hospitals has more than tripled in the last 10 years. She's co-director of the Patty and J. Baker National Palliative Care Center, professor of geriatrics and palliative medicine, Catherine Geisman, professor of medical ethics, and was founder and director of the Hertzberg Palliative Care Institute, all at the Icahn School of Medicine at Mount Sinai in New York City. Dr. Meier was named one of 20 people who made healthcare better in the US and was elected to the National Academy of Medicine of the National Academy of Sciences in 2013. She received the Gustav Lienhard Award, which is one of the most prestigious awards of the National Academy of Medicine, in 2017, as well as a MacArthur Foundation Fellowship in 2008. Dr. Meier served as a Health and Aging Policy Fellow in Washington, D.C. between 2009 and 2010, working on both the Senate Health Committee and the Department of Health and Human Services. She has over 200 peer-reviewed publications, and her most recent book, Meeting the Needs of Older Adults with Serious Illness, Challenges and Opportunities in the Age of Health Reform, was published in 2014. She's a visionary leader in her field, and I'm pleased to welcome her today. Along with Dr. Meier is our very own, we do claim possession, of Dr. Lara Weiss. She's a 2021 graduate of our own Harlem Family Medicine residency, who we're proud to say landed a fellowship in the #1 rated geriatrics and palliative care program in the United States, right here at Mount Sinai. What a treat to have you both with us today. We thank you both for being with us. We really look forward to your remarks. Thanks.
Thank you so much, Neil. What a lovely introduction. And it is really my pleasure to be presenting with Lara. Lara and I hang out together on Tuesdays in clinic, and I've had the privilege and really the joy of seeing patients with her for the past few months. And thank you for sharing her with us. And I will share my screen. There we go. Okay, can everybody see my title? Yeah? Okay. So I'm going to talk, I hope, for about 20 minutes, and then Lara and I are going to have a conversation about one of our patients that we saw together. And I'm going to ask Lara to reflect on her experience transitioning from being a family medicine resident to also being a palliative medicine fellow, and the ways in which those experiences are intersecting and illuminating each other. So I titled this talk, All You Need Is Love, with a subtitle of Human Connection During COVID and Beyond. And I want to make these remarks in the context of the insanity going on around us. So we are now 2 years into this pandemic, and our country, the wealthiest country in the world, leads the world in total number of cases and in total number of deaths. And if you look at it per capita or per 100,000 population, we are number 5 in the world after Bulgaria, Hungary, Brazil, and Poland, not usually thought of as our peer nations in deaths per 100,000. There have been more American deaths from COVID than from the Spanish flu, making COVID the most deadly pandemic in US history. As of earlier this week, more than 838,000 individuals have died from COVID, and is thought to be roughly a 50% underestimate, particularly from the early days of the pandemic. The US accounts for about 4% of the world's total population, but 20% of deaths from COVID. And as I'm sure you are all very well aware, this pandemic has not hit all populations in the US equally, highly disproportionate impact on persons of color, Black and brown people as compared to whites. Not something new in our country, but illuminated, magnified by the last 2 years. And in fact, this pandemic has had the highly unusual impact of reducing life expectancy in the United States, not something that has really ever happened in this and the past century. In 1920, 1930, there was this huge gain in life expectancy that was associated with separating drinking water from sewage. And it actually occurred before the era of antibiotics and modern medicine. And was a almost 20 to 30 year leap in life expectancy from an average of in the 40s to an average of in the 70s. Since then, life expectancy has increased, albeit slightly, in all populations in the United States until now. And during this pandemic, life expectancy has declined by nearly 3 years for Black people in this country, erasing all the gains of the last 25 years and decreasing 1 year on average across the population. So I hate to belabor what seems perfectly obvious to those of us working in the healthcare system, but the impact is profound and not, I think, not fully understood or fully felt yet. So we have a lot more uninsured. 70 million were already under or uninsured pre-pandemic. And then there have been at least 15 million losses of employer-sponsored insurance due to COVID. Big financial losses for our employer, Mount Sinai, other health systems, many clinicians. Aside from those of us who are working in capitated value-based payment environments where the money comes in every month, whether we see patients or not. Worsening and obviously much more visible racial and ethnic disparities, public health infrastructure failure, and not to mention impact on the workforce in healthcare in the United States, profound levels of burnout, exhaustion, hopelessness, helplessness, resignation, and illness that makes our beautiful marble and glass buildings basically empty towers when there are no people to take care of patients. So again, I think this is very obvious. We have become numb to the staggering coronavirus death toll. Death is everywhere and yet nowhere in America. And that is continuing 2 years later. And these are just some photos from the paper of some of the individuals who have lost their lives due to this pandemic. And many of you may have seen photos of the Washington Mall about 5 months ago, and a memorial to those who have died from COVID, who, when the number was somewhere around 500,000. And there were white flags planted on the mall for each individual up to that point who had died. Very, very moving photos of remembrance. And this is an aerial photo of the Washington Mall, and it reminds one nothing so much as the graveyards in France from World War I. It's just massive scale of loss and death. So I think we have to begin with that context because it is affecting human connection for every single person really on the globe. And there are major implications for our field of the consequences of social isolation, of loneliness, and of trauma, and of grief, and particularly of complicated grief as major determinants of health. I'm just going to read to you an opening paragraph from a report from the National Academy of Medicine that was done before the pandemic, published in 2020. Remember, these are pre-pandemic statistics. Human beings are social by nature, and high-quality social relationships are vital. Like many other social determinants of health, however, social isolation, which is a quantitative, objective lack of social contact, and loneliness, the feeling of being isolated, are significant and underappreciated public health risks. Social isolation and loneliness are associated with poor health outcomes, including higher mortality, depression, and cognitive decline. Recent research documents the prevalence of social isolation among older adults. From the NHAT study, 1/4 of community dwelling older adults are considered socially isolated. And from an AARP Foundation survey, more than 1/3, 35% of adults age 45 or older are lonely. A 2018 study from Kaiser Family Foundation found about 1/5 of adults say they often or always feel lonely, feel that they lack companionship, feel left out, or feel isolated from others. Now, remember that these are pre-pandemic statistics, and think about the magnifying effect on these numbers of the pandemic. So, as I said, social isolation is a quantitative measure. It is literally the number of human beings you come into contact with over the course of a fixed period of time. As mentioned, it's about 1/4 of older adults, and that's pre-pandemic, and it's associated with mortality and has more impact than obesity, smoking, or inactivity on likelihood of death, and is also associated with an increase in risk of cognitive impairment, whether because the cognitive impairment itself is what leads to progressive social isolation, or the social isolation as a contributor to the development of cognitive impairment is unknown, but it's a strong association. Loneliness, again, is subjective. The feeling of being alone, it affects a huge number of people, again, pre-pandemic, about 1/3, higher rates of depression, anxiety, and suicide. In heart failure patients, a 4-fold increase in risk of death, and a nearly 70% increase in risk of hospital and ED utilization, and is markedly increased among especially first-generation immigrants, LGBTQ people, and those who have a history or current abuse of any type, or trauma. The epidemiology, as mentioned before, and these data are from 2021, but were gathered pre-pandemic, increases as people near the end of life. Predictors of both loneliness and social isolation as being poor hearing loss, difficulty preparing food. Predictors of loneliness being a woman, being in pain, being incontinent, and cognitive impairment. And in social isolation, the predictors are being unmarried, being a man, low education, low income, and interestingly, being white. So what are the implications for us? Almost everyone interacts at some point or another with us, with the healthcare system. And for many, it is their only or most frequent human contact. If we don't look for it, we can't know and we can't help. So our job is to screen, just as we screen for hypertension or diabetes or depression, identify and intervene. And these factors are just as or more important than blood pressure, weight, A1C, or cognition screening. And the indexes listed here are those with the best validation and reliability. The Berkman-Syme Social Network Index, which is a measure of social isolation, and the UCLA Loneliness Scale. So, lest we feel hopeless and helpless, we can influence the future and what our patients' experience are by focusing on what is under our control. And a lot is under our control. So here's a study of whether remote social contact, like we're doing now, can replace in-person contact. And these data are actually mid-pandemic and were published late last year. Unfortunately, despite some increases in remote contact, this is the National Social Life, Health and Aging Project. There were, not surprisingly, increasing prevalence of loneliness, depression, and lower happiness. And unclear in this study what the reasons were for low overall use, whether access, ability, broadband, access in the neighborhood. And clearly, we need to do better, both on restoring in-person contact and figuring out how to facilitate easier and more widespread use of remote technology. So this is a great study, was published in August, and a very simple intervention in a senior center in the Tenderloin district of San Francisco, a very diverse, low socioeconomic status setting that did something very simple. They identified people who were lonely in their senior center, and they matched them to a peer. So for example, if you are a Black middle-aged woman with a diagnosis of cancer, you were matched to another Black middle-aged woman. If you were an Orthodox Jewish person in the community, you were matched to another Orthodox Jewish person. And perhaps not surprisingly, this peer support was profoundly effective on reducing loneliness and improving social well-being. And all they did is they paid $20 an hour to these peer supports from a local grant that they got. And they gave the peers training and supported them with a team, social work and nurse, who they could turn to if they identified something concerning. And it markedly reduced loneliness and improved social well-being. So really would be very inexpensive to scale this innovation, yet what we pay for in this country is ineffective $56,000 a year drugs for dementia that don't work. It's just remarkable how our policy ignores effective intervention and invests in very expensive, ineffective interventions. And these authors suggested adding a few focused measures of social connection in addition to common assessment instruments to identify individuals at risk. And each domain can be assessed through a single question. Individuals should be asked if they feel isolated, lack companionship, or feel left out. Apparently, when they tested the question of do you feel lonely, that was associated with stigma and people were uncomfortable answering it. So these are the terms that they landed on. The question on social isolation is how many people do you feel you can depend on or do you feel close to? And then thirdly, ask people about their access to phone or video communication capabilities, whether broadband, whether having a device, whether knowing how to use it. And the reason that I, as a palliative care clinician, and us talking about palliative care is that palliative care very much has had the role of being a bridge to human and social connection for patients and families and our colleagues, frankly, during this pandemic. A pandemic, and this is from a Lancet article from last year, is a cause and powerful amplifier of suffering through physical illness and death, through stresses and anxieties, and through financial and social instability. Alleviation of that suffering in all its forms needs to be a key part of the response. And these are just some quotes that programs around the country sent into us about from patients and families really during the earlier phases of the pandemic. We didn't realize that someone still provided medicine that spoke to the experience of the patient and family. Thank you for advocating for me. We didn't feel like anyone was hearing us before you talked to us today. I feel less alone. My only regret is we did not find you much, much sooner. You have been a bright light in a dismal time, and this is just a selection. And what do we do differently, perhaps, than our insanely overworked, overextended, running from pillar to post colleagues? Our main intervention is sitting down face to face and being present and listening. And because that's how we train people, that is the most important thing you can do, this is the impact. So what's essential during COVID-19? And this was a lovely article in the Washington Post by a third-year medical resident at Cornell. And she's now a critical care fellow. She went from internal medicine to critical care, but this was her headline. Coronavirus has given doctors a new job, palliative care. And what did she mean by that? It's not just about treatment. We also need to make sure that our patients feel seen. And as I said, that's the key intervention in palliative care. I'm going to read to you from an article written by a dear colleague of mine, Stu Farber, who was a palliative care pioneer back in the early 1990s and became a friend of mine back from those days. He died of leukemia in 2015. His wife received the same diagnosis some months after he did. They both used the time before his death to write about what they were learning, and as patients who were also health professionals. And their observations were as follows. First, living with a fatal illness taught them that uncertainty is a given and control is an illusion. They saw clearly how their doctors were deeply invested in that illusion of control. Yet every clinician Anna Lou and I have interacted with is more afraid of death than we are. They focus on solving the problems of our illness with little awareness of how we want to live our lives. It's a paradox. The clinician is focused on treating the illness that threatens life, but the life of the person who is ill is invisible. Third, even when he expresses his grief and sadness, I have been amazed at the distance my providers keep from my grief, and when it is touched, how quickly they are bound to fixing it. Most of my clinicians are so busy protecting themselves that being with me is not possible. As I sit with my medical caregivers, I see fear of failure at the center of their consciousness, with death being the ultimate defeat. And Lara and I are going to present a patient that we saw together about 6 weeks or 8 weeks ago, in whom these words were profoundly true. So what do we know that people want for medical care? When you talk to your family members and they tell you about their experience with a clinician, any clinician or a doctor, what do they talk about? They talk about whether that person was kind, whether they were warm, whether they were nice, whether they established a relationship. In surveys, patients and families prioritize clinicians who listen, are caring, compassionate, and explain well. Strong relationships, meaning and purpose are universally among the highest priorities in human life. And that has implications for what we do all day. And not only what we do taking care of patients, how we teach and how we conduct research. And I'm gonna close with a few more quotes. This is a quote from one of my favorite books by John Berger, written a few decades ago, called A Fortunate Man, in which Berger, who was a powerful observer of the human condition, followed an English country doctor on his rounds for a whole year and wrote a book about it. And I really commend this book to you for insight into what we do. And here's one of the quotes from this book. In illness, many connections are severed. Illness separates and leads to a distorted, fragmented sense of self. The clinician, through relationship with the patient and by means of the special intimacy allowed, compensates for these broken connections and reaffirms the social meaning and value of the patient's sense of self. And David Barnard, another long-term colleague of mine, a philosopher and medical ethicist writing 25 years ago, wrote similarly, the sting of illness and death is the specter of broken relationships and the loss of the world. Over and against this threat stand the efforts of caregivers and companions to embrace the sufferer and continuously reaffirm his or her capacity for relationship. And a few more. Francis Peabody, a Harvard professor, speaking to the graduating class in 1927, famously said, "The secret of the care of the patient is caring for the patient, caring about the patient." And some of you may have heard of Avidus Donabedian. He was the father of the field of quality measurement, the structure, process, outcome, infrastructure for quality measurement. And he wrote during his experience with colon cancer, "The secret of quality is love." And here's the full quote. "Systems awareness and systems design are important for health professionals, but they are not enough. They are enabling mechanisms only. It is the ethical dimensions of individuals that are essential to a system's success. Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God. If you have love, then you can work backward to monitor and improve the system." And last but not least, a poem from Mary Oliver, a poem titled "Praying." And then we'll move on to Lara. "It doesn't have to be the blue iris. It could be weeds in a vacant lot or a few small stones. Just pay attention, then patch a few words together and don't try to make them elaborate. This isn't a contest, but the doorway into thanks and a silence in which another voice may speak." So I'm really curious, because Lara didn't hear this talk earlier, but I'm really curious about her experience midway through her fellowship, and how I believe it was exemplified by our interaction with the patient she's going to present. So let me turn it over to you, Lara.
Yeah. Well, first, I just want to say that I am absolutely honored to be presenting with Dr. Meier today, and she's incredible. And I certainly feel like the luckiest budding physician in the world that I get to have her as my preceptor in clinic. I think, yeah, I didn't hear this presentation, and Dr. Meier asked me to reflect on my fellowship and the topic. And it's funny because so much of what was said was what my thoughts were and what I had written down. I guess, to start, I guess I'll talk about, my experience and my thoughts in relation to this case. I'm not going to present this case in the way that I think we're probably used to presenting a case in medicine, but this case was a younger gentleman who had hepatocellular carcinoma. He had interacted with the medical system many, many times, and he had undergone multiple lines and modalities of treatment, and he had been to multiple hospitals and multiple different places to receive care. And he came to see us kind of very late in the process after having been through all of that. And he certainly seemed to be at the end of his illness and really functionally not the same person that he was before. And it seemed that, the questions that were most paramount to him and most paramount to what was about to come in his life, he did not feel prepared for. And no one had addressed what to expect and what he needed to do to prepare for what was to come. And so we ended up spending many hours with him, trying to do all that work very, very quickly. When we both knew, when we left the room to discuss that, time was very short to be able to do all of these things. And we said to him, I wish you had been able to come here sooner. And, his family said how, when we spoke to them about what to expect and what the next few weeks would look like, and what he would need to have in his house to prepare for what was to come, his family said to us that this was the first time that they had ever heard the patient speak so much and be so engaged in a medical conversation, because really that was what was important to him. That was what he wanted to know, and no one had talked to him about that yet. And I think that was one of my earlier cases in the fellowship, and, shifting to how my thoughts about care have changed. I would say that, from family medicine residency, I think it was amazing prep for palliative care, because, we're taught, first and foremost, to be advocates for our patients, and also to be advocates for what we believe in, and what policies we want in the world. And that's extremely important in palliative care, to, as Dr. Meier said, to love your patient and to be an advocate for your patient. But I also feel like there's been a large shift in myself in the way I approach care. And in medicine and in medical school, we're always taught that the worst possible outcome is death. And all of our tools that we have are built for, life prolonging measures. And all of our M&Ms and cases that we discuss are usually about medical error or mortality. And we all, I would say, like, probably a secondary outcome that comes with that is, litigation and avoiding that. And we push, medicines and treatments to avoid these, worst possible outcomes that we learn about. But in reality, for the majority of our patients and for everyone in the world, death is inevitable. And in palliative care, we acknowledge that, and we help people prepare for that. And I think in doing that, our worst possible outcome shifts to being discomfort. And, the worst possible thing could be a patient feeling uncomfortable or feeling unprepared for what's ahead of them. And our M&Ms kind of really focus on areas where that occurred. And I think, in doing that, you're really treating the person in front of you and learning about the person in front of you and what's important to them and what's important to their care. And you're acknowledging that, you can't avoid the inevitable, but you can make the path to getting there as patient-centered and comfortable as possible. And I would say, like, the tools that we use to do that are really, human interaction and communication, rather than these medications and the machines. And yeah, I'll pause there just to see if there's anything that you want to add, Dr. Meier, about the case and reflections.
Thanks, Laura. Do you want me to call you Dr. Weiss?
No.
And you have to use my first name too. So even though I started out by talking about this unconscionable number of deaths during the pandemic, and the case that Lara and I chose is someone who was sent to palliative care clinic with basically less than a week to live, and had never been talked to about that fact, even though he could experience it. I want to hasten to remind you that most of the patients we take care of are chronically ill and not dying soon. So we have patients in the palliative care clinic that I just came back to clinic last year, patients that I saw 10 years ago, in this case, someone with myeloma, who is still coming to palliative care clinic and who has gotten through her very difficult course with ongoing support from our fellows over a 10-year period, for not only pain and consequences consequences of treatment, actually, neuropathic pain as a consequence of treatment, but also the really profound spiritual, existential, emotional, social costs of serious illness. So a lot of the patients we take care of are living with serious illness and its consequences, and we work in tandem with our colleagues in other specialties. This particular patient, it was so stark to see him start to make eye contact, which he hadn't been doing, when we asked him what was his understanding of what was going on with his illness and what questions he had about what's going on. And, he went straight to, am I dying, basically? And because, here were people who were not going to run away from that and not going to abandon him with that reality. And I felt very distressed that his clinicians, whom I know and who are otherwise caring, very, very capable people, totally abandoned him at this most difficult phase of his illness by not being with him, literally not showing any human connection. And that he didn't get that till he met two strangers roughly 7 days before he died. Well, at least he got that. But what's wrong with our system that this is considered okay? As my colleague Stu Farber said, he was a fellow physician in the same healthcare system, and his physicians abandoned him. They couldn't be with him because it was too painful. So that issue of human connection, relationship, being seen, the theme throughout everything we've been talking about. It's hard to do when we're as busy as we are. And, our raison d'etre is to be busy. We kind of miss the point about being with patients.
And I certainly think that COVID has made that, an even larger barrier. I think, in the last, several years, even before the pandemic, we were talking about this being an issue with us always, being in front of the computer and doing work at the computer, especially in primary care. But it certainly became especially prevalent in COVID. And I don't think it's just with providers and patients, the shift to telehealth a lot of the time, it's also, between providers. We're, doing grand rounds and our lectures and everything virtually. And it's a huge shift in, human connection and human interaction. And it's, really meaningful in a field that, is where communication is so important. We spend so much time making sure that there's good communication and making sure that we're, signing out appropriately and rounding and having closed loop communication with nurses. And so much of that has been lost with, having to stand 6 feet away from each other and wearing masks and, doing everything virtually. And I certainly think that when I started fellowship, I definitely noticed that from the other side. And also how palliative care was such a bridge there. Many consults I got at the beginning were, it felt like I was kind of bridging communication between different teams, or, helping residents communicate with their colleagues. And it was really interesting to see. And yeah.
I sometimes think of palliative care as family therapy, because, it's family systems theory that kind of applies in the culture of medicine. And each specialist focuses assiduously on his or her own organ system or disease type and believes, fantasizes that somehow everything else is being cared for. And it is not their job to think about, whether this person has transportation to get home, or lives in a 4-story walk-up, or the elevator's broken, or they can't get their meds, or the reason they didn't show up for their last appointment is they couldn't get a ride, or have enough to eat, or be sad, be lonely, be in pain. And I often reflect back to why during residency, instead of choosing cardiology or oncology, I chose geriatric medicine. It's because I'm a lumper, not a splitter. And it never made any sense to me to focus on one part of the human being. And at that point in geriatrics, it was a holistic field that deliberately said the society context is important, the family's important, the socioeconomics are important. Every part of this person impacts every other part of this person. And that made cognitive sense to me. And modern medicine, which with its legion of partialists, didn't make sense to me. And patients pay the price for that, and you can see it every day. Unless there's a family medicine clinician or a palliative medicine clinician who forces the partialists to communicate.
Yeah.
Because otherwise they don't. And it's striking to me how we tolerate this as a field.
Yeah. And I certainly think there are a lot of parallels there between family medicine and palliative care. You know, we really look at the family dynamic and how that impacts a person's care so much. And oftentimes we treat so many parts of one family, so can really see that in front of us and can really, you know, bring things together. I think, you know, something that I learned also in my hospice rotation is just really the importance of taking care of the caregiver. And I just wanted to mention that as well, because I think that's, you know, so important during this pandemic as well. You know, the burnout and everything that we're seeing with the caregivers is so significant. And so I think I have found myself a lot of time during fellowship being, you know, a support system for my colleagues during consults as well, which has been an amazing pleasure, in addition to taking care of patients.
Yeah. I found one particular phrase to be really, really helpful in talking to colleagues from other specialties, or getting them to connect with the human being who is the patient. And what I say is, this is a really tough case. So just, you know, acknowledge the suppressed pain and grief of our colleagues, you know, who are running off to the next patient, not because they don't care about or have feeling for what the patient is going through, but they just don't have any tools for expressing it or making it conscious. And so when I say something like, this is a very tough case, it opens the door to acknowledging that. And as consultants, that's a big piece of what we do.
Absolutely.
So I wonder if it's time to go to Q&A.
Yeah, and I just wanted to reflect on, you know, the image that we keep seeing is of the providers during COVID, especially in the ICU, sort of being the surrogate family. You know, that's been one of the, I think, most difficult and most moving things to watch. Are the stories of how people's connections with their family were completely disrupted, and how the providers became sort of their family members. It's really heartbreaking to sort of see those stories and see those images on television, and I just understand how critical, you know, what you said, Lara, that the idea of just being caregivers to the caregivers what that must have been like, and having spoken to some of our residents who were, in that role, how incredibly difficult that role was to play. That was a new role for everybody.
Yeah. And yet we should not underestimate its power of healing and restoration. And we feel bad that it's not the family there, and we feel inadequate, and we feel like we wish it could be better, but we shouldn't let that sense of discouragement or hopelessness stop us from being with the patient, because that is the only thing that matters. And we can do that.
Autumn, do you want to go to the questions? I think the first is a comment, but if you go to Dr. Gale's question.
Yes, this topic has everyone waxing philosophical this morning. Thank you for sharing your vulnerability with us at the Mary Oliver poem at the end of your presentation. Knocked my socks off. All right, so here we go. Let me expand this. So Dr. Gale asks, mortality begins at birth, and having any conversation about death and dying is uncomfortable for both patients and clinicians. Clinicians, because it may highlight our failure to prevent or delay death, and for the patient, the stages of death and dying they will experience. How do we sharpen our tools to be better at and for these conversations?
You want to talk, Lara, about what you've experienced that perhaps is starting to give you more skill and comfort in these conversations?
Yeah, I think, the first thing is I've learned that, patients really want to talk about this. They want to be able to talk to you about what they're scared of, and, what the next bit is practically going to look like for them. They want to be able to manage their expectations, and there is so much healing in being able to tell someone, what to expect and what to prepare for, because it's so tangible and practical for a patient. And I think as providers, in medicine, we often don't really realize that. It's like, it's important to figure out if, as I decline functionally from my disease, I'm not going to be able to get up the stairs. What am I going to do? And just preparing people for those practical things that are going to happen is super important. And also just supporting them emotionally with what comes with that is, such an important role as a healer and as a doctor, supporting the emotions that come with that.
So the kind of training that's available on how to initiate these conversations, because I certainly didn't get any training on this during my residency or my fellowship in geriatrics. There are some really accessible, high quality resources that are free. One is the CAPC website, Center to Advance Palliative Care, which has a series of courses on communication skills, including breaking bad news and giving serious news, as well as running a family meeting, negotiating conflict, those sorts of things. And, if you were a surgery intern, you wouldn't be expected to go in and do an appendectomy just because you happen to be there. But the way we have it now is clinicians are expected to know how to conduct these very complex communication procedures with no training, no mentoring. But communication is a procedure, and it can be taught, and obviously should be taught because it's essential to quality care. And that those training options are there. And that is one of the things that perhaps in relationship to your balance groups is something that we could do together as departments. So there are online courses which give you the vocabulary and the sense of what it's like. And then there are actual virtual, very effective virtual trainings from Sinai faculty on communication, and that's something that would be pretty easy to set up for your trainees. But an example is if you're meeting a patient for the first time, and in our case, the patient Lara presented, didn't even really know why he was here. He had schlepped 2 hours from Long Island through traffic and everything else, incredibly, to see us. And he's sitting there, and we explained who we were and what our function is on the team, and asked him what his understanding was of what was going on with his illness. So that's the first question, because it's not telling the patient something, it's apprehending where the patient is and what they're able to understand and what the other doctors told them. Because if, for example, he had said, well, my belly's swelling, he had ascites, as opposed to, I have cancer all over my body and I'm dying, that we're in two completely different places for the conversation, right? So you start by asking the person what their understanding is, and then asking the person how they like to get information. So I always say some of my patients like to know every detail about their illness. Others of my patients prefer a more general outline or want me to talk to someone in their family. What kind of person are you? And so that doesn't stigmatize the person who doesn't want to know. And there are a fair number of people, maybe 10, 15% who don't want to know. So you have to honor that, because if you don't honor that, there's no trust. And so the first, it's called ask, tell, ask. So you do a lot of asking before you tell anything. And then when you've told something, you stop talking, you allow silence. And then you ask the person in a kind of teach back to tell you what they understood from what you said. So I'll say something like, sometimes I'm not very clear. I use words that aren't easy to understand. I want to make sure that I was clear in what I just said to you. What did you hear from what I said? And that's when you hear that they didn't take in anything that you said, right? Or that they understand part of it, or that they're trying to come to terms with it. But it's a lot of sitting with open body posture, not crossing your legs, not crossing your arms, sitting opposite the patient, making eye contact, and asking a whole lot more than telling, because that welcomes the person into the relationship, really. We can send some resources on that to Autumn, and she can send them out.
We'll share them gladly. Thank you, Dr. Meier. I have another question, which is very similar. What are some questions you ask to check if the patient is at risk of isolation, abandonment, confusion, or if they have a sense of discomfort? And what are signs that you look for in patients as red flags for being at risk of feeling abandoned, isolated, or confused?
I'm gonna take a crack at that, Lara.
Sure. It's a very good question. I think, we talk a lot about asking patients what worries them about their care or just in general. And just that simple question and then listening, you can find out a whole lot. And also then on the other side, asking what's important can bring up a lot of answers to a lot of those questions as well.
Yeah.
Yeah, I think listening is the really biggest thing.
Right. And listening is enabled by asking an open-ended question and being genuinely interested in the person and in the answer, as opposed to looking at your watch, one hand on the doorknob, typing, looking at the screen. I mean, patients interpret that quite accurately, that you're not present, and you're not. So it's a sort of bodily discipline and body language discipline. That's required too.
Well, our last question was about resources. The book, the website that you recommended with trainings, which, like we said, we'll send an email after this to everybody with resources. Are there any other questions?
Yeah, this is Red. Could
Right.
I? Thank you both. Fortunate Man actually is also one of my favorite books. It really should be required reading. It's an incredible narrative about what it means to be a physician in the community. But what I'm thinking about is this issue of being present and how we're trained not to be present. And I personally think it's one of the hardest things to do, right? Especially now. So thank you for the comment about ballot, because I think that's part of it. But just sort of a comment and maybe a reaction. I think, if we think about, we wash our hands, we sort of cleanse ourselves between patients to not transfer an infectious agent from one patient to the next. But we do that all the time emotionally. It's very hard to transfer from one patient to the next without sort of checking yourself. So I'm wondering if you could comment specifically on what we can do to get better at being present. And one thing I heard from somebody who is an experienced preceptor, the first question they ask is, what interests you about this person? Before you get into the details of why they're there for that visit, because that sort of connects with what this is about, is love. Like, how can this person feel cared by the end of this visit could be part of an assessment. Just wondering what your comments are about this and what you've, Diane, sort of what you've experienced over the years to help those of us in teaching to help people learn how to be present.
So again, I think there are body language and self-discipline that enables that. So in addition to washing hands, I also teach that before you go into the room, you stop and you take a deep breath. It's because that helps you focus on the next encounter you're having. I am a stickler on body language. You sit down, you uncross your legs, you put your arms on your legs, you get as close to eye level as you can with the patient, because just that bodily position causes you to be more open to the patient. It's like where your body is affects your attention and affects your capacity to connect. So, and obviously sends a strong message to the patient that you're present. It makes it hard for us to avoid reality, break eye contact, be on our way somewhere else, be worried about something we didn't get done, because your body is helping you focus. So that as well. And I actually think it has to be role modeled in the clinical encounter. I don't think telling people, I think I go in the room with Lara and I sit down and I assume that body posture and I make eye contact with the patient. And that I don't explicitly say to Lara, look what I'm doing, although perhaps I should. But I think it makes a big difference. And I think we underestimate the impact of the choreography in some way of the encounter on healing and human connection.
Wow.
Great.
This this has been a very powerful experience. Brings back to me a number of situations, and just to lighten things up a little bit, I have been going through some old papers, which, you know, I guess I'm tending to do now that I'm getting older and wanting to sort of recollect certain things. And I found a recommendation that was written by one of my teachers in medical school. And it said that he thought someday I would grow up to be a great doctor, but I needed to learn to stop being so informal with my patients. And that at one time, he even caught me sitting on the end of my patient's bed, talking to them. And I thought, you know, it's the reason that just jumped in my head is because we unteach all of the things that you're trying to teach all the time,
Right.
you know, and in so many subtle ways, you know, we undo this. It's not just that we take a neutral position. You know, you pointed out we're still approving $56,000 medications and not paying attention to all the things that we know people really need. And we just continue that. It's not just the battle against neutrality. It's a battle against something that's constantly working in the other direction. And
Right.
I think that's why it's so powerful. So I had one last question, which is, are there policy things that we should, you know, we're, as family docs, we're often policy advocates as well. What are the couple of big policy issues that we should be paying attention to that would help us be enabled to do more of what you're saying and what you're teaching?
You know, I'm increasingly thinking that we need a measure of relationship-focused care. We need a quality measure about continuity that incentivizes continuity and incentivizes relationship building between the patient and clinician, because right now our system incentivizes fragmentation. And, you know, the average number of the average Medicare beneficiary sees 10 different clinicians in the last 6 months of life. And that's not rare. That's the norm. That's the mode. And, you know, none of the things we've been talking about can occur when they're spending their life schlepping from one appointment to the next, one stranger to the next, each one responsible for 1% of their body. So I've been thinking a lot about a measure of continuity and quality of relationship. I don't know if anyone's working on that, but that's where my head is moving.
Mm-hmm. What we measure gets attended to, right?
Precisely.
Lara, any last words?
You know, it's been amazing to be able to be back here with all of you guys and to present with Dr. Meier. And yeah, I hope I could keep talking about all this stuff for a very, very long time, but I know everyone has work to do. So thanks for letting us talk with you all about this.
We hope that all the things you learn, that you will be with us for a very long time and be able to continue to be part of this process with us. So thank you. And thanks, Diane, for really inspiring messages. Have a great day, everyone, the rest of the day, and prepare for the big snow that we're supposed to get on Sunday and Monday. So we'll be spending Martin Luther King's birthday looking at snowstorm. And anyway, thank you again. Have a good day.